try to get back on schedule. Our next presenter is Scott Sumners. Okay, can I have your attention? Thank you. Our next presenter is Scott Sumners, and he received his Doctor of Pharmacy degree from the University of Houston College of Pharmacy, of course in Houston, Texas. He's licensed as a registered pharmacist in the state of Texas, and he currently works as a staff pharmacist for Oakdell Pharmacy, which is a chain of for-profit pharmacies here in San Antonio that serves a lot of the long-term care facilities. And he's going to talk with us today about medication dosing in the elderly. So please welcome Mr. Sumner.
Thank you. All right. Oh. Well, first of all, I think you have the handout there in front of you, and I have to make a confession. When I was looking over this again after I sent in the thing, I realized that not all of my references are on the last page. So if you don't believe me, or if you want to check something out that I have that I'm talking about, or you just want more information in general, I do have an updated list. If you would like that, I have that, and then there are also some copies that you can ask around for. So I apologize about that. Up here. Medication dosing in the elderly. Just a few more things. I work for Oakdell. I'm near the San Antonio area. I come from Houston. I was trained there. And Oakdell Pharmacy is where I currently work. We do several different things. One of those things that we do is service long-term care facilities, assisted livings, and nursing homes, and so that's a part of what I do there. Okay, just kind of a layout of hopefully what we'll do here. I'll give you an introduction, some points that you've probably already heard of some of this morning, but I'll hit those again. Just some introduction about the elderly in San Antonio. One of the questions that I want to look at is really, is there a difference between dosing elderly and dosing non-elderly adults? Is that something that we need to consider? Is that a real question or issue? And then Bearish Criteria is what I'm going to spend a substantial portion on. You may be familiar with that. It's a guideline that we'll talk about in a little bit. It talks about medication considerations, and then I'll have a few concluding points, and then if we have some time for questions, we'll do that. Just to start, I thought it would be fun to look online to see, since I am new to San Antonio, what are the demographics here. And these are just some numbers that I pulled up to help me focus on the number of folks that I'm dealing with. But in San Antonio, from the 2000 U.S. Census, apparently 7.3% or over. 7.3% doesn't really drive home the point to me, so I wanted a number, 83,000 folks that I walk around every day, 83,000 of them this talk could apply to. And then 65 years plus, 10.4% or almost 120,000. 120,000 makes me take my job a little bit more seriously, because that seems like a larger number to me, and I can affect more people. And then medication use, it was referenced in the last presentation and surely before as well. As we age, our bodies decline in function, and a lot of times a way to combat that is through medication. So as we get older, it's not uncommon for us to have more prescription medications, and so that's what I want to talk about. Just more of an introduction, some brief points to go over. As we get older, like I said, our bodies function less well typically. So more comorbidities, more problems, more diabetes, more blood pressure problems, more cholesterol problems. And then some things that can be seen with higher incidence in the elderly they're seen more in the older folks would be osteoporosis, Parkinson's disease, but not all the time. Alzheimer's and dementia, those are more frequent. And then some things, especially with regard to medications. Medications all have side effects, regardless of how excited the drug company is that puts it out. They all have side effects. And some specific ones that can cause particular harm to the elderly folks would be vertigo, which is kind of like the dizziness sensation of the room is spinning and I can't hold myself up. And the other one is falls, and then just general incontinence, you losing the ability to control your body the way that you would normally do that. So the first question is there a difference between the elderly and non-elderly adults? Finkel and Holbrook, and another study by Harmon. Harmon's put several studies out that look at this question, and there are 5 or 6 maybe big issues that are talked about. The two major ones that keep recurring seem to be something called oxidative stress and myocardial dysfunction. Just in brief, if you're not familiar with those two, cellular processes are going on in our bodies all the time. Cellular processes are going on the atomic level to keep our cells functioning. It's how we break down medications. It's how we digest our food. It's how we do everything. And at that atomic level, certain things can happen to where atoms are charged in your body, and it's important for them to be balanced all the time. If those atoms are not balanced all the time, you can get something that is typically called a superoxidase, and all that means is I'm an atom that likes to destroy things, essentially. And so if you get some of those atoms floating around in your body in different cells in different locations, those atoms can cause harm, and they can cause dysfunction in your cells. They can one big issue with Alzheimer's deals with that, dementia deals with that. Lots of processes in our body deal with this oxidative stress. One thing to consider there, though, is oxidative stress is not unique to the elderly. It happens in all of us. Our bodies have, we've been given ways to combat that. We have processes that can overcome these bad atoms that are floating around. But as we get older, you've lived a whole lifetime with these bad atoms and then the trying to reconcile that. And so sometimes that balance can be outweighed. Maybe sometimes your correction processes don't work as well as they used to. And so the oxidative stress can have more of an effect as we get older. The other thing is kind of a subpoint to that is mitochondrial dysfunction. The mitochondria is an aspect of our cells that it really is the energy powerhouse of our cells. It's what makes our cells function. And so there are a lot of very important processes that go on there. And one of the things that happens in your mitochondria is several processes that can cause oxidative stress. And so oxidative stress is something that can be very important in your mitochondria, and that's something that we can think about as well. And so that's another cellular issue of getting older. And hopefully as we go through this, I give these 2 points just to help reinforce the fact that as we get older, our bodies function less well. These 2 purposes would point to the reason for that being that there are some problems in the cells where the cells are either being destroyed or they're not functioning properly because of these oxidated, they're called radicals in our body that can destroy our cells. So that's the reason that I wanted to bring those up. Things to consider when we're looking at any patient really, but especially these are the things that I like to make sure that I'm asking each time I counsel or review someone that's elderly and on some medications, are these 4 points. The first one, and in pharmacy world, we like to remind ourselves of AD and E, so I'm going to refer to that again at the end. This will be what I'm talking about. The first one is A for absorption, and that's usually decreased. We were just talking about diabetes in the elderly patients, and it can happen in diabetes in anyone, but sometimes your gut will not absorb the medication as well. Many of the medications that anyone takes, elderly or not, are oral, and so it goes through your mouth, it goes down to your stomach, it goes into your gut. Well, the drug doesn't always work until it moves from your gut into your cells or into your body. So if you're not absorbing things as well, then a medication that usually works really well in a non-elderly adult will not work well in an elderly adult because they can't absorb it as well. Some reasons for that are just slowing transit time of the gut, and so the pill doesn't, if it's a tablet that you're swallowing, it doesn't move through your gut at the same rate that it would somebody else. And that can cause problems. The cells that you have that line your gut may not work as well, so you can't pull the drug up into your cells. So absorption is a big one. The other one is distribution. Medications, when you take them by mouth or when you get them as an injection or however you get a medication, it has to be distributed to something in your body. Most medications will be distributed to all of your body, but particular medications will only go in some places. One thing that just came to mind is Zithromax or azithromycin, if you've ever had a Z-Pak. That medication, the phrase that we use to remember where that goes, tissue is the issue. Zithromax does not go in urine, so you can't use it for a UTI. Somebody that has a urinary tract infection is not going to collect there. It collects in tissue. And so that's just an example that some medications will focus on a particular type of tissue. It may be fat, it may be muscle, it could be any nerve, it could be anything. And so as we age, one of the major distribution changes that happens in our bodies is decrease in muscle mass. And so if the way that a drug works has anything to do with where it goes in your body and proportions of how much muscle do you have to how much water do you have or how much fat do you have, that changes as we get older. And so that needs to be considered as well. Metabolism possibly decreased. The two major locations that drugs are metabolized in your body are either your liver or your kidneys. And as we get older, our liver usually will decrease in function and kidney function will decrease as well. And if those are the places that metabolism is going on, you need to consider if I'm giving this drug and it's not metabolized, what's going to happen. The last one is excretion. Again, the kidneys and the liver, the two main areas, not the only areas, but the main ones. And so again, if those two organs are not functioning the way that they did 20 years ago, we need to consider that when we're dosing someone so that we're not giving them the same dose. Because if we do give them the same dose, but we don't get rid of it, then that dose hangs around longer, it acts longer, maybe it acts more aggressively than you would expect in an adult, and so that's something to consider as well. With that brief overview, the next big question is there something to help us consider it? Those four issues, A, D, M, and E, are something that I try to think of when I'm counseling anybody, any patient, regardless of age. But is there some kind of guideline to help me figure out, which drugs may or may not be more appropriate for the elderly, which may be less appropriate? And of course, if I'm asking a question and giving a talk on it, there is. And that one is Bearish Criteria. And just some general background about that, if you're not familiar with this. This is a consensus report. It is periodically updated. I think it was first put out in maybe '89. It may be a little bit earlier than that. I think I saw a most recent one in within the last several months, but I haven't read that one yet. The one that is out there and that people that are going to be concerned with Bearish Criteria, the one that they're using, there was an update in '03. So that's the one that I'm going to talk about. Fick and colleagues did that in 2003. And this is not, there are two different, broadly speaking, there are two different kinds of studies that you can see in medicine. One is a study that takes a drug, asks a question, and then performs an experiment on it. That is a dogmatic type of study. You can say, we have proof, these are the numbers, this is what happened. The other type of study, and that's what this one is, the second type of study is a consensus report. You ask a bunch of experts that have been, in this case, geriatrics for years, they've been practicing there. You find somebody who's been working in geriatric renal issues. They've been working there for years, and so they have not only the knowledge of literature that's out there, but they also have the experience. And so this study was actually done that second way. It's a consensus report. And they contact these folks and they put all the consensus together, and so that's what this report is. And what it does, that being said, this is not a dogmatic, this is the way that it has to happen in every case. There's a lot of literature in cardiology that would say, the first thing that you dose somebody on if they have hypertension is a diuretic, which you just talked about a few minutes ago. There's a lot of literature to support that. This is more of a, let's keep ourselves reminded that these are some issues that could be possible for our patients. So I wanted to give you that background. This is the list on the 2003 version. If you're thinking that maybe there are just one or two drugs, and I'm going to talk about two drugs today. If you're thinking, well, I don't deal with those medications, I don't prescribe those, or my parents don't use those, there is a whole list here. And some of these I personally hold more closely to than others. Some of them are very patient specific. Some of them sometimes you just have to use. But the idea of this report is to give you an idea of, let some red flags go up when you're dosing these in the elderly. Two drugs that I want to look at is Amitriptyline or Elavil, and then Propoxyphene, and more commonly in America that's a combination of Propoxyphene with Tylenol. The brand name for that is Darvocet N100. It comes in different strengths, but those are the ones that we're most used to here. So this Bearish Criteria, it tells you whether the drug is, it gives it a high, medium, or low, I think are the wordings that it uses, about how concerned you should be, and then it gives you a reason why. And this is the reason why on amitriptyline. It says it's because it's a strong anticholinergic and sedation properties. Amitriptyline is rarely the antidepressant of choice for the elderly. And I do see this. We consult at Oakdell, we consult with nursing homes all the time. I come from Houston where I did nursing home consulting, and we had several there that we did. It's not used all that often anymore. I think some good literature is out there to suggest that this is not the first antidepressant to use in the elderly. But every once in a while I do see it. And then the two major things that this says can happen are anticholinergic effects and sedation properties. So I'm going to run through these. There are three studies that I want to go over quickly with you. The first one compared amitriptyline, and then the control was fluoxetine. You may be more familiar with that as Prozac. And so they were comparing those two. This was that first set of studies I was talking about. When I first started, I said Bearish Criteria was the second one. The first one is one that you can be a little bit more dogmatic about. This study is in that first category, and the reason for that is it was a double-blind, randomized, and a lead-in control study. So it was set up well. The problem with this study is it only had 65 people in it. It's hard to make a broad sweeping statement about all of America with all of our diversity if you only have 65 patients, so that's a downside. All the patients were older than 60. The duration was 6 weeks. That's important because both of these medications, independently, they take 3 to 4 weeks to start working themselves, so that it was well done. But the two major points down at the bottom was if they used amitriptyline, I forget I have a pointer here. If you use amitriptyline, dizziness, decreased attention, increased confusion, and increased weight. So essentially, folks gained a little bit of weight and they were confused all the time. If they were taking the control drug, which happened to be fluoxetine, they had headaches, somnolence, which is drowsiness as well, and general pain. So there were issues with Prozac, but they were less than using amitriptyline. In the second study, and all these, I thought this was interesting the other night when I was looking at these. These are all from 98 and 2000. Kyle and colleagues, they used another drug in the same class as Prozac. This one, the brand name is Celexa, the generic is citalopram. And they compared those two, and the doses are up here on the top. Those are common doses that we use in non-elderly adult patients. Again, it's a double-blind, multi-center study, so this study falls in that first category of studies as well. There was a better number of patients here, so you can put a little bit more weight on what this study said. There were more folks in it. The patients were between 65 and 90, so that's the age group we're looking at, and it lasted 8 weeks, which is appropriate. And what they found was more confusion, suicide, hallucination, and anxiety in folks that were taking amitriptyline, which is not what you want in an elderly person who may be dealing with dementia or Alzheimer's or something else anyway. And what they found in the citalopram group was nausea. Now I do need to say, if you can read the real small print down at the bottom, these numbers that I have here are p-values, which means it's significant and I can speak very confidently about them. This second study here, the items that they found here were not statistically significant. And so I can't stand up here and say, every time you give someone amitriptyline, they're going to have confusion, suicide, hallucination, and anxiety tendencies. I can't say that. They didn't find it. Those were trending. These were issues that they found in those patients that they did not find in the other patients. And so that's the confusion through anxiety there. They saw that in the amitriptyline folks, but they didn't see that at all in the Prozac folks, in the fluoxetine. Sorry. This last one, by Rosenberg and colleagues, again, they used citalopram, the same drug as the previous study. They used normal dosings on that as a double-blind, multi-center study, so that was good. Puts it in the first category of studies that we were talking about. And there were about 300 folks in there. That's a decent number. The folks were in the proper age range that we're looking at. The duration is good. The dry mouth and constipation that they found in the amitriptyline group, that's a correlation to the anticholinergic effects of amitriptyline. And so this is a manifestation of that. And then in the citalopram folks, nausea and diarrhea again. So as you can see, the list is a little bit longer on the top. It's a little bit more sporadic. This is on the top, the amitriptyline. It's a little bit more sporadic underneath. And so from that, in all three of these studies and in Bearish Criteria as well, the general conclusion is you don't want to use amitriptyline as a first choice for depression if you're seeing an elderly patient wanting to start them on something they've never been on anything before. The second thing that I wanted to talk to you about, the second drug is propoxyphene. And that, like I said, that was usually in combination with Tylenol. And there are some big issues in the literature of kind of fights back and forth as to whether this combination of Darvocet and 100, whether that is really more effective than Tylenol just by itself. My opinion is that if you're going to be dosing someone for mild to moderate pain and you're going to be giving them Darvocet and 100, you're really just wasting their time and their insurance copay. Just go get them some Tylenol, unless you have another reason why. And I would say that about all these drugs. Unless you have another reason that is medically compelling to use the medication, I wouldn't recommend it. And this is what Bearish Criteria says. It offers few analgesic advantages over acetaminophen, which is Tylenol, yet it has the adverse effects of other narcotic drugs. Propoxyphene is a far removed derivative of opium, and so a lot of the confusion, it's a central acting drug, which means it works right in your brain to help you get rid of some of the pain as opposed to working at the site of pain. And so that's an issue here as well. There are lots of studies that would recommend if somebody needs to be on a mild pain for mild arthritis or even moderate arthritis, just use Tylenol unless there's not a reason for it, so you don't get these other side effects. And we're going to look at that a little bit. There was a study that I wanted to look at with regard to this, and it again was it was a conglomeration of studies all put together. Poe and colleagues did this in '97, and this has a pretty substantial number of folks that they used. They looked at over 2,200 folks when they were compiling all this, and then the types of pain are listed there, and these are common in elderly folks, especially arthritis here. They looked at 26 different studies, and their goal was to put all the information from the 26 studies together and say, can we come up with some kind of more cohesive answer to should we use it, or should we use that combination product or not. 6 of the trials are really important for what we're talking about today. They compared Tylenol versus, I'm using brand names, I shouldn't do that. We're doing acetaminophen versus propoxyphene in a combination, or placebo, and they had 3 different groups in their studies, and they were able to compare those well. The majority of these studies, 21 of them, did look at individual ones, so they would compare acetaminophen with placebo or combination with placebo. And that's actually important because we want to know, one, does propoxyphene in a combination work better than acetaminophen? If you're adding on another drug, you should get some kind of benefit from it. But then these 21 down here on the bottom, and we'll see it, they kind of lean more towards there's not really any difference. Hopefully that'll be a little bit more clear as we get through this. So I have 3 graphs I wanted you to talk about. And really, on these graphs, just this top section here is what we want to look at. Over here on the side, these are the different studies that they're comparing. I mentioned that there were multiple studies. This graph talks about acetaminophen, this is the European word for acetaminophen, versus placebo. And if the line is on this side, this is the center line here. If the dot here and the whole duration of this line here, if all of that is on this side, then that study concluded that the treatment, or Tylenol, was better than nothing. If you have pain and you got to use something, it would say Tylenol works. Whereas if the line is on this side and the whole duration of the line here, if it's all over here, then it favors placebo, meaning that the drug really didn't do anything. If the line crosses, if this horizontal line crosses the vertical line at any point, then the study doesn't tell you anything. That's essentially what this graph's telling you. So these 6 studies here would suggest that acetaminophen is better than placebo. If you have some kind of pain, Tylenol does indeed work. We knew that already. This last study was non-conclusive because the 2 lines cross there. The second graph that I wanted to show you looks at the combination of acetaminophen and propoxyphene. And again, if it's on this side, it favors the active drug. If it's on this side, it favors the placebo. And as you can see, all of these studies concluded that indeed Darvocet or propoxyphene and acetaminophen are indeed worth something if you're going to choose something to treat a sort of pain. This is the interesting one. And as I mentioned before, there were 6 studies in this conglomeration that looked at head-to-head studies of acetaminophen or the combination of the 2 together. There are only 2 listed here, and I thought that was curious. The reason that they only listed 2 and not the 6 was because the other 4 studies that were out there didn't list variance. They didn't give you an idea of how good their numbers were. And so because they didn't give that information, they weren't included here. But as you can see from these 2 here, the horizontal line definitely crosses the vertical line. And so what we can gather is it neither favors the combination nor does it favor Tylenol by itself. So from these 3 graphs, we can see that acetaminophen is useful for pain. We can see that propoxyphene plus acetaminophen in the combination is useful for pain. But this last graph would suggest that the combination drug is no more useful, no more beneficial than just using Tylenol by itself, acetaminophen. And more expensive, right? This last one here is some more data that this study came out with, and just kind of some side effects that it had with it. Essentially, these are weighted relative risk ratios. So if you're taking a medication, what's the risk of you actually doing something? If the number is 1, then there's no difference between the 2. And some of the other numbers, the numbers underneath here in parentheses, give some statistical significance to that. But here it says weight. Let's see. Any side effect, if you were taking Tylenol, you were likely to have some kind of side effect. That's essentially what that's saying. And this number is saying that if you took Tylenol, it's possible that you would be drowsy. From a pharmacological standpoint, that's not something that would be expected. And so that's actually an interesting point. This last one here, the combination, if you were taking acetaminophen plus propoxyphene, then they saw that there was a pretty good significance that you were likely to be dizzy, which is important for the elderly because, as we were talking about a few minutes ago, concerns about falling, breaking hips, multiple things that can happen if you get off balance or just dizzy. The last study that I want to look at, the last bit of numbers that I wanted to look at was, is Bearish Criteria useful for us? It's this idea, this conglomeration of information. There's a whole big list that we saw earlier. But is that something that's really clinically useful to us? And Chang and colleagues did a study. And this one, they actually just called folks and were gathering data that way. They started out with about almost 900 folks, and they were all elderly, and they did a telephone survey 1 week after their office visit. So the patients had taken the medication. They had the possibility for taking the medication for a week. They may or may not have taken it as they were directed. And then this last line here, 11% of this 882, 11% were taking medications that were on the Bearish Criteria list. The Bearish Criteria list is consider or don't take these, but 11% of them were. And then about 23% of the patients, of the total number of patients, had some kind of adverse drug event. So regardless if they were on a Bearish Criteria drug or not, they had some kind of side effect. This one, this table gives some relative risk. So again, if the number is larger than 1, then you're more likely to have the issue that we're talking about. And down here at the bottom, you can see that this is relative risk if they're taking a Bearish Criteria medication. So anything on that list that we were talking about before, if they were on it, the relative risk was 15.3 for them to have any kind of side effect at all. The number of medications was about the same. This second line here is really saying, if I'm on Bearish Criteria medications, am I going to be taking more medications or less medications than somebody who's not on that? And there's some difference there. A history of side effects, adverse drug reactions, the relative risk was well above 1. And then again, non-compliance with prescribed medications was well above 1. We can guesstimate and surmise about all of these. If I had to guess, and it may be inappropriate to do so, but if I had to guess on these, this last one, non-compliance, if you're more likely to have a side effect on a medication, most people are more likely to not take it. And so if you're on a Bearish Criteria medication, it would be possible that you have more side effects, you wouldn't want to take it. Again, here, that would suggest that you're having more side effects, possibly because you were on a medication that was on Bearish Criteria. Now, just to kind of take a step back here, the general non-elderly adult individual, if you take more medications, you're more likely to have side effects from it or drug interactions. You start out here with a small number of medications, and the medications are just kind of floating around in your body, maybe like this, and they don't really touch each other because there are just not many of them. If you start taking more medications, then you start increasing the chance of medications interacting, and you increase the chance of adverse drug reactions. That could be just as simple as, now you have 8 drugs in your system instead of 2, and so as they're floating through your body or floating through your cells, they're more likely to interact and more likely to cause a problem, or they could be more likely to cause a problem on their own. And that would be in the non-elderly adult. In the elderly adult, even with a small number of medications, there's an increased chance of you having a drug reaction because you may be taking one of those drugs that are on the Bearish Criteria list. And so whether you're taking 1 medication or 26 medications, you could still be having some problems. But then if you follow this down, just like the previous slide, when you use more medications, you have a higher chance of those multiple medications interacting because they do different things, and then you increase your chance of adverse reactions. The point here is that even with a small number of medications, if we dose someone on a medication and fail to consider ADME, absorption, distribution, excretion, and metabolism, then they're more likely to have a problem with that. This slide, I just want to move by. Just in conclusion, again, more clinical trials are needed in geriatric pharmacology. The studies that I was looking at comparing acetaminophen with propoxyphene, those were actually done in younger folks. I was looking over some of those, trying to remind myself of the exact age grouping, and I think the average age on those studies, the highest one I saw was something like 45 or 50. And so those studies were done in younger folks. And we do need more studies in the elderly so that we can figure out exactly how to treat them better. The other issue here is considering the patient population. Again, consider, is the absorption changed? Has that changed because they're older? Maybe they've had some GI surgery in their earlier years, or maybe they're diabetic and their GI system is not moving medication like it should, or maybe they're just older and they just don't absorb it as well. The other issue would be distribution. Does the change, and this happens to everybody, as we get older, like I said before, our percentage of muscle mass goes down, and that turns either into fat or water. And so is that shift from muscle mass to non-muscle mass, is that going to affect your drugs? And in some pretty important medications, it can. So considering that, metabolism, again, how are the kidneys and the liver working? Those are the 2 big things. If you had a particular drug that you were looking at, you should sit down and say, how is this drug metabolized, and then does my patient have any compromised issue with regard to that? And then excretion as well. Can this patient get the drug out of them? Like I said before, if the patient can't get the drug out of them and it stays active in your body, if your body doesn't break it down, then that drug's going to do more of what it does, and that could be problematic. The last point that I wanted to say was just consider using Bearish Criteria in your own practice. It's not, like I said before, it's not a cut and dry, if you're on these medications, you're going to kill your patient. That's not the purpose of Bearish Criteria. The purpose of Bearish Criteria is to bring up some issues about medications that are commonly used. Maybe, I want to say maybe 30 years ago or so, Amitriptyline was one of the drugs that was used for depression. And so we just use that in elderly as well, because elderly folks can be depressed just as well. But, and so we would just translate that and use it in the elderly. This guideline would say, take a step back, consider all of the ramifications of the drug that you're using, and consider, is that still appropriate for my patient, knowing how that medication goes through all of these 4 processes here. I put a thing for questions in here, but I also wanted to give you in your handout there, I wanted to give you the citation for this 2003 updated version of Bearish Criteria. This is something that you can pick up. It's a free access journal that you can get online. It should be listed there. You can actually, if you even if you just Google FIC and then do Bearish Criteria or something like that, you'll come up with it. And I just wanted to show there are about 4 different pages. And this is hard to see, so I'll try to describe it. But the way there's a lot of commentary and a lot of explanation in Bearish Criteria on the medication that it talks about, but the things that I really like about that, if I'm going to use that criteria, is it gives these really neat tables of, one of the tables actually goes drug by drug, and it tells you why you should consider this drug in an elderly individual. Some of these others, they kind of break it down into subgroups, like psychiatric drugs, which are a big issue in the elderly, and the side effects that they have. It breaks it down into cardiovascular drugs and those types of things. So sometimes it may be a little bit easier to find the data. I guess in finally concluding, I would say I would recommend that you use Bearish Criteria if you're a practitioner and you're seeing patients. But again, consider that it's not the final word. The purpose of Bearish Criteria is to bring some issues up so that we're making sure that we look at everything, every aspect of our patient when we're talking to them. So, any questions, or do we have time for that? Oh, the last one? This one?
Yes.
Okay. Did you have this in your handout?
Yeah.
Okay. Okay.
I apologize if I missed it.
No, that's right.
But what are the statistics as far as the percentage of folks that actually do expire from either these issues or the addition of alcoholism involved, or taking their meds without food when they should, or taking them with food when they should not, or taking supplements, just the ability to follow for each med?
Right.
Do you have any statistics on how many folks actually do expire? Just wrong.
So I think she was, I'll relay to make sure I got your question right. She was asking what are the statistics on individuals expiring because of medication problems, be it they don't take it correctly, or they don't know how to take it correctly, or they have adverse reactions, or maybe they're taking something that's on this list. I honestly don't know that. I would, from the studies that I've read on Bearish Criteria, they don't, depending on the medication, it's, morbidity is not necessarily the first endpoint that is looked at. A lot of time, the first endpoints that we looked at in the studies, I'm sure those statistics are out there. I'm just not sure of them. But a lot of the endpoints that are used in the studies are things that you would expect from the drugs. So, like from the Amitriptyline drug that we looked at, a lot of the endpoints are cholinergic side effects, and so they won't. You can tell if you read the studies that 7 patients dropped out because they passed away. But usually they're looking more at what are the side effects from it. So, sorry, I don't know.